5 o'clock. Call the meeting in order of the Health and Human Services Board on April 16th at 5 p.m. in room 1400 of the Government Center. Roll call, please.
Sean Anderson.
Present.
Mike Barkalow.
Present.
Kathy Finley.
Present.
Kathy Leaf.
Present.
Lisa Lind.
Present.
Deb Lindeman.
Present.
Dave Osnes is excused. Julie Smith.
Present.
Greg Telejohn.
Present. Thank you. Minutes were in the packet. Any changes or objections or questions? If not, the minutes will be approved as presented. Any public comment tonight? Any public comment? Going once, twice, 3 times public comment? Hearing none, we'll move on. Business, financial report for March 2025.
Okay. Good evening. I'm Faye Strinke. I'm bringing you the financials. The financials this month are through March of 2025. A couple of things you might have noticed if you look at our State Human Services grant, so our 43560. Last year at the same time we were 202,000. This year we're at 746. Our April payment came in March 27th, so we doubled up our March payments, which is why those are high this month. Next month, if it stays early, it'll go. Otherwise, it may wait till May. So next month, the numbers will be virtually the same. Other things to point out, our purchase services are actually very similar to what they were at the same time last year. But if we scroll down and look at behavioral health, so behavioral health is higher. Our Winnebago expenses have been high the past 2 months, plus we've got placements at Trempolo, so behavioral health is running high. Some of those are expected to be long-term, so they may trend high this entire year. Within children's services, though, other thing to point out, CCS is low as well. So our census is a little bit down. A lot of the purchases or services for that program are contracted. So as census is low, those purchase services will be low and the revenues will be lower, kind of at that same ratio.
Let me just jump in on that. So CCS is 100% state funded. So when our expenses are lower there, it actually hurts us because we're not going to get reimbursement. So when she's talking about purchase services are the same as last year, the ones that are tax levy funded are up and the ones that are state funded are down. So that's bad news she's giving you. Yeah. Continue, Faye.
So within children's services, our purchase services are lower than they were at the same time last year. And just a little bit of breakdown within children's services. We've got child protection, kinship, youth justice, children's long-term support, children's COP, and targeted safety support. Child protection is where we've had a lot of those high dollar expenses. Those are pretty much running exactly the same as they were last year. Youth justice is where we've kind of seen a pretty significant drop. So last year we had a double whammy with a lot of additional placements in youth justice and then high dollar placements in youth justice. That one kind of is trending back down. Also with children's long-term support, there's a big transition from WPS funding it as a third party to Gainwell. Services that in the past we maybe paid vendors for, then we billed and got reimbursed. The state has said that's a conflict of interest. So these providers have to figure out how to build themselves. So we're going to see our purchase services go down. Again, that matching revenue will go down as well. We did budget it that way, so that was something we knew was coming. So we'll see that line down a little bit this year.
And this is the line item that's been running $1 million over budget the last couple of years. You can see it's been at $4 million the last 2 years in a row, and we're still only budgeted at 2.9 million. I don't have enough money to put into this pot to catch up to that and run the whole rest of the county.
So there wasn't, I mean, the good news in ADRC are last year catered food and unprepared food, we had done some significant changes in our operations, so we saw some hits to the budget there. This year, they're very much on target and trending pretty much the same every single month, so we're not seeing any huge increases yet from inflation or anything there. Healthcare campus, so good news, and this is again, no tax levy involved here. This is all services that are paying for, fees that are paying for the services being provided. They're ahead of where they were last year at the same time. You'll notice our staff salary and fringe as the census has gone up. Census has gone, or staffing has gone up, but our purchase pool staff, so down here, that is down as well. So we were at 236,900 last year. We're at 168 this year. So we are still using pool staff, but significantly less than we have in the past. We did open up Kitty Roads. So we do have census here now from services being provided. We still have our last, so we spent, you know, the large funds getting that opened up. We have our last payment will come in here in April to reimburse all those expenses. And that's $119,000 or something we're expecting from the state for that. Any questions for me on the financials? I think so. One other last thing to point out, when we are seeing like this negative amount here, a lot of this is due to that transfer to debt service. So we've talked about this the past couple of months. That will kind of take us to the end of the year to absorb that expense hitting all at one time. So, all right, thank you.
Thank you. Any other questions? Okay. Next item on business, high utilizers of care, early intervention strategies to lower costs and improve outcomes.
Thank you, Mr. Chair. The reason I wanted to talk about this tonight, this topic, was in large part due to what Faye just talked about and Ken pointed out, was the high costs that we're paying for people that end up in hospital settings or children that end up in residential care centers that costs a lot of taxpayer dollars. And this term, high utilizers of care, might or might not be familiar to you, but this really refers to a group of, I should say, a population of folks who maybe 5 to 8% or so of the population that uses the most health care, a disproportionate amount of health care. These are often people with chronic conditions like mental health and addiction and physical health problems, people without insurance who don't qualify for Medicaid or haven't enrolled in Medicaid or don't have private insurance and can't afford it, et cetera. People that might be unhoused, people that might be unemployed, et cetera. So this small group of individuals with these kinds of health problems often costs the most, at least 50% of all healthcare expenditures. I don't want to sound like I'm blaming the victim here. These are folks that need healthcare, and because of their conditions, oftentimes, or their circumstances, don't access it. And the reason this matters is because our department, hospitals, often see these folks come to us for help. And they come to us, though, late, after their illness has already progressed or their condition has already deteriorated or their circumstances have. And they're already in crisis of some kind, whether it's physical or behavioral health crisis or something. And they interface oftentimes also with law enforcement. So they're often these same folks that not only end up in emergency departments or our crisis services, but they end up in jail or involved in the criminal justice system in some fashion. So why this matters is if we can be effective at providing preventive and early intervention services to this population, we can prevent a lot of costs and improve their outcomes earlier in the process. So they're not waiting until they're very sick or the situation has devolved to the point where they need crisis interventions of some kind. And again, since I've been here since 2020, virtually every board meeting or committee meeting that I'm in talks about these folks that wind up in jail or involved in the criminal justice system who have behavioral health conditions and really don't belong there. They're nonviolent offenders simply by virtue of their behavioral health conditions, though they end up in situations that land them in jail oftentimes. So our intention over the past few years has really been to focus on how do we intervene earlier in this so that we can support people that are affected by these social determinants of health that have these high risk factors for requiring hospital levels of care or that might end up in jail. How do we intervene earlier in different ways to engage them that prevent that from happening? And insurance is an important part of that. If we can enroll someone in Medicaid, obviously that allows them the opportunity then to get behavioral health services, but also allows them the opportunity to go see a doctor and treat conditions before they become severe so they don't end up going to a hospital. Or to treat their condition, their behavioral health condition, so they don't end up interacting with law enforcement and going to jail. And the thing is that people who don't have health insurance, people who don't have Medicaid or some other form of health insurance, still get health care. They just wait until they're really sick or some kind of emergency happens before they go to an emergency department, and then the hospital has to treat them through uncompensated care for the hospital. And that raises all of our insurance rates, right? So they still get health care, but they don't get the traditional preventive kinds of care that those with insurance can access. So it's really important that as many people as we can that are eligible, we get enrolled in Medicaid so that they can get these preventive doctor's visits and behavioral health visits and don't wait until their condition has devolved. And the relevance, of course, to St. Croix County is what Faye talked about in the budget is the cost to the county for people that are placed in places like Winnebago or children that are placed in high-cost environments are typically paid for through tax levies. So those are things that we think we can do better as a county at preventing and lower the costs involved for taxpayers while providing better services for those people that need the interventions that we can offer them. And that kind of leads into the next section about the intersection of public health and public safety that I also talk about from time to time. But that's really the notion that public health and public safety are intertwined. They're not separable. If you have health conditions like behavioral health conditions, for instance, that are untreated, you more often then see people ending up in jail with them because their conditions are untreated and their symptoms land them in positions where they are arrested for usually nonviolent kinds of offenses, and then they end up in jail. So that's the population within this high utilizer group that we're focused on, not just focused on, but that we've taken an interest in looking at. So how do we do better at treating this group of folks who cycle through all of these high-cost, poor outcome environments like jail, emergency departments, and crisis services. And if you go to, I think it's page 36 of the packet, I focus just really on behavioral health, that division for the purpose of this presentation, just to outline what we're doing there to try and make a difference in outcomes for these folks and to lower the costs for the county. So we have a variety of funding sources in HHS. As Faye knows, there's a billion different funding sources that she has to manage. But we try and utilize the ones that we can and some newer ones that came along to apply towards these early intervention strategies. And just looking at the behavioral health division itself, we've implemented a social worker within the jail, embedded in the jail, that works with folks who have mental health and addiction-related needs. Bill Schultz is the guy that we hired, and he's doing a great job, but he's very busy. And then we have mental health co-responders that you're aware of that were funded through the referendum about a year ago. Right now, I think we just have one. We have an opening, don't we, Shar? Huh? Oh, good. We just hired a second co-responder. So that's another effort where mental health co-responders go out and co-respond to an event with law enforcement to try and de-escalate the situation and hopefully provide that person with support so that law enforcement can go on their way and the person doesn't end up in jail or a hospital. We fund the jail social worker, we call it that, for Bill's position. We fund that through opioid settlement dollars that we receive. And then the mental health co-responders, like I said, are funded through, well, they were funded through a referendum to increase tax levy, but we still look at other ways to offset those costs. The state opioid response grant is another source of income that we've used for getting people enrolled in treatment efforts and support efforts around opioid use so that we can prevent opioid addiction from progressing and hopefully treat those folks through paying for their residential treatment if they need that, or providing them with other kinds of support in the community, peer support, harm reduction efforts and things like that. We have 2 peer support specialists that are funded through ARPA through the end of this year that we contract for through Northwest Passage. Certified peer specialists are a thing that I've been promoting for a long time, not just here, but in Minnesota and earlier than that, where I think they're a really cost-effective position for helping people and supporting people with addiction primarily, but also with mental health conditions, and really having a professional relationship with them ongoing that helps to support them in their recovery. And it's really been, in research too, but it's really been effective just in the programs that I've overseen over the years that have utilized peer support. The Abuse in Later Life, or the Office on Violence Against Women grant that we received, is also another thing that Shar has been heavily involved with, that looks at domestic violence in older adults and ways in which we can strengthen our adult protective system. There's a new potential pilot that Shar again is looking into. It's a jail-based competency program, but it looks at diversion for people that end up in jail who may have been charged with a crime and may have mental health or addiction-related conditions, and looking at how we can divert them away from jail to a more supportive kind of environment. And then if they follow through with those recommendations, their charges would be dropped at the end of the intervention. But it's another way to try and divert people away from jail to the kind of help that they need. We offer an intoxicated driver program for people arrested for OWI and how we can support them to prevent future operating while intoxicated charges. We provide court order assessments, a lot of harm reduction strategies. We have a public health vending machine now in our vestibule that offers the public free harm reduction products like Narcan, fentanyl test strips. We offer all kinds of public health items like COVID test kits and things like that. And working with the Justice Support Services Department on what's called a sequential intercept model. It's a mapping process. This is an effort, I won't go into detail, but this is an effort that began quite a while ago in our CJCC Behavioral Health Subcommittee, where we started looking at, again, our whole system of care around this population that intersects both public safety and public health, and how to design a system around those folks when they enter the criminal justice system to divert them away from jail, away from, potentially anyway, away from charges that could be dropped if they follow through with some of the interventions that we offer. That's in its kind of early stages. Dr. Ghali and myself and others are involved in that effort. It includes DA's office and sheriff and all kinds of folks. So we'll keep you posted on that. But there's so what I was thinking of when I did this was not just to put together a list of different interventions that we're doing related to criminal justice involved people and high utilizers of care and health and human services, but it's really to get some feedback from all of you around the policy direction in terms of moving in this direction where we're focused more in a coherent way around those folks that often intersect with law enforcement and the jail, and those folks that we also see at HHS, often the same people. And they also circulate through emergency departments and crisis services. So in talking with Shar, our deputy director, the idea would be to devise a more, almost a package of services that we offer to this population in particular to try and make a dent in these folks, to improve their outcomes and to reduce the number of folks that end up staying in jail for nonviolent kinds of charges related to their addiction or their mental health condition. And we'll work together, if this is a direction you would like us to go in, to really design a set of service areas around this population and present it to you as sort of a more coherent, again, package of strategies on how we intend to do this, putting together all these different funding sources and different grants and pilot efforts and all of that to say, here's together how it looks, and here's the anticipated or measured outcomes that we're looking at, the factors that we're looking at to measure outcomes to see if we're being effective in doing good work around this. I don't know if I explained that really well, but did I? Okay,
So
you get the gist of it, I think.
So right now, we're kind of operating in silos?
No, I don't think so. I think just previously, I would say historically, human service departments tend to shy away from getting involved with criminal justice systems and clients. I mean, we serve them when they come to us as a referral from those areas, but we often don't get directly involved in working in partnership with, like, justice support services, the jail, the sheriff, other law enforcement agencies directly to say, let's together come up with a strategy that works for you, that works for us, and that can help to achieve a similar goal. And that's what we're moving towards, is more engagement with the public safety side of things, so that we're sort of intertwined with them to address these kinds of conditions and folks.
Yeah, I serve on public protection and judiciary as well. So the intersections are obvious, and I fully support this approach because it does help us engage with folks. The mic went off. Oh, okay. Engage with folks early on. Oh, you turned me down a little. Uh-huh. I get it. You haven't even heard me get fired up yet. Anyway, I fully support it because I believe in upstream tactics that help us prevent jail time for people. And if you talk to the sheriff, and when we do our annual jail inspection, he talks about it every month in our meetings about the mental health issues that they face with people that they are dealing with in the community, and how valuable the behavioral co-responders are, but also that, you know, they're not a substitute for Winnebago. Our jail isn't. That's not what we're here for. So I fully support going upstream with these tactics and working together like you're proposing.
A couple questions for you, Bob, to kind of help us wrap our minds around what you're doing in these departments. Could we see some sort of report where we're seeing number of clientele or customers coming in, number of personnel that are attached to these departments, and then a cost breakdown?
Yeah, sure. That would be part of what we would want to present. And that's kind of the work we're doing in the sequential intercept model, is to really get our heads around all of the different justice related interventions through the DA's office, through the Justice Support Services, the sheriff and everybody, and what we're doing, and put it together and say, here's the population we're looking at, the number of people involved, here's the cost involved, and here are the people within our department that serve these populations, and how we could either reassign them or assign a portion of their time to doing some of this work, and we'll break that down in terms of we wouldn't be hiring additional staff. It would be a matter of devoting current staff to these kinds of issues and what that looks like. That would be part of what I'm talking about, Supervisor Barklow. So that's part of what I'm saying. We'll put together a coherent package to show you a strategy that you can look at and have more detail involved with. Yeah.
Numbers are good for me.
Okay.
Thanks.
Yeah.
Right now, we're using opioid, I can't say it, funds for the behavioral in the jail, right?
Opioid settlement dollars, yeah.
What happens when that runs out?
That's fairly long-term.
Is it?
Ken could correct me. I think it's, yeah.
How long?
Yeah, we had enough funds to fund that position for about 20 years.
Oh, we do, okay.
Yeah, we kept getting more and more settlement dollars, so I think we should be okay for a while.
Oh,
So
okay.
what do we do 20 years when that happens?
Not your problem, Greg.
I'm gonna be around, I'm gonna be around that long.
Sean's going to be the only one left in this room, so.
Very possibly.
And Chair Telejohn, too, we use some of those opioid settlement dollars to fund a position, substance use professional embedded in children's services to work with families affected by substance use as well, and for the same intention, really, to prevent those high acuity settings.
Good. Any other questions? Oh, go ahead.
I just want to echo what Kathy said. I mean, upstream is really where we need to move. We're never going to have enough dollars to pay for Winnebago or any of these crisis intervention services, but the sooner we can impact the health of these individuals upstream, the better off we're all going to be, because it all comes back to us.
Thank you. And Dr. Finley, there's a public health metaphor you might be familiar with where I'll paraphrase this, but there's a couple of people standing on the bank of a river and they see a person floating down the river drowning. One of the people jumps in to go save them, brings them back, and then they see one or two other people floating down the river drowning. Same person swims out to get them, and he says, how am I going to ever rescue all of these people floating down the river? And the other person says, why don't we go upstream and see why they're falling in the river in the first place? I mean, that's a good metaphor for what we're trying to accomplish here, and an example of an upstream intervention.
Anything else? Thank you. Next item on the agenda is communicable disease update.
And Mr. Chair, I invited Heather Prigge, who's our public health nurse, has been for 18 to 19 years, I believe.
I'm in my 18th year. I
Yeah.
guess. I had to think about it when you asked me that earlier.
And Heather's going to provide the communicable disease update with, I think, some help from Dr. Finley, with a focus on measles. With the measles outbreak in the country, we wanted to make sure people had information about measles. So I'll turn it over to you, Heather.
Well, thank you. Yes, I was thinking, how can that be already, though, that many years I've been here? And before that, I was working in Minnesota as a public health nurse there for 9 years. So I've been in public health now a while, and I am excited. So thank you, Dr. Finley, for presenting with me. This is nice to do that, and we'll kind of bring some different information with different perspectives. So she'll jump in a little bit. We'll tag team. I just wanted to start with a brief overview of communicable diseases and how they can be spread from person to person and from animals or an object, and they can be caused by many different issues, by bacteria, viruses, fungi, and parasites. But the good thing is not all of them are mandatorily reported to the state or local public health. So let's just spend a second here looking at this kind of information. Reportable diseases do require prompt reporting to state or local health departments. Really across the nation, there are some differences between states. But then they're also really there to protect the community because of their interest by reason of contagiousness, severity, or frequency. And then depending on what the issue is or the illness, it requires different coordinated follow-up requirements. And here's a little information, state and local requirements. We are required as a local health department to follow up and to provide communicable disease control efforts in our county. And we have a really good partnership with Wisconsin DHS and constantly learning and updating guidance and working with different sectors in the community. So that's been really helpful. I do have to have my paper notes here with me, so sorry about that. I couldn't get my notes to be on presenter mode, so just give me a moment there. The other system that's really helpful with local health departments in Wisconsin is the Wisconsin Electronic Disease Surveillance System. So we have kind of a quick and direct connection with labs and local providers who do the reporting and public health to document and follow up and then connect with states so that they can connect with CDC and look at the bigger picture of spread of certain illnesses as well. As far as it goes for some requirements, you're probably aware there are actually three categories of reportable diseases in Wisconsin. The third category is handled by the state. And so Category 1 and Category 2 illnesses are do require local public health follow-up. And Category 1 need kind of immediate response and reporting. And local health departments, as we act very swiftly because there are control measures that we can implement that have a bigger impact the sooner we can get to it. So that's really the biggest difference with Category 2 and Category 1 is the timing of reporting and what we can really do to help control the spread and help people get support that they need. Here's a little picture just so far in this year in St. Croix County. The nursing team has followed up on 192 diseases, and in 2025 so far, we've had 21 cases in Category 1 and 171 cases in Category 2. There's a sample. I think our biggest Category 1 has been pertussis. Wisconsin and nationally has dealt with a lot of pertussis. So that's what we're seeing there as an example. There's a lot more illnesses and diseases, and on the Wisconsin DHS website, you have all of the illnesses that are in those categories. Another, just kind of pulled it out here, outbreaks are considered a Category 1, but one of, I think, the things we do pretty well is connect with our long-term care. It is mandatory that they report when they have an outbreak, and an outbreak is 3 or more cases of certain illnesses. So we've had several of those in our long-term care sector. It doesn't mean that they're doing poorly. The reporting is there so we can make sure and work with them to help sure they have the guidance and resources they need in-house because they do a lot of work. Our facilities work really hard, and so public health is right there just to kind of make sure they have what they need and the support we get from the state as well with those sectors is really awesome and very helpful. Kind of brings us to our next slide here is in the communicable disease realm. I think nationally we're seeing this on the news. If you're watching, the measles outbreaks so far this year really have been an uptick. And I have data in here from April 3rd because the data on the CDC website is updated every Friday, and I had to submit this information. So if you give me a minute here, I do have an update for you. What you see on the slide, 670 confirmed cases. That went up to 712, I believe, confirmed cases, and now 25 jurisdictions throughout the United States are reporting cases, and we have 7 outbreaks and 3 deaths so far with this measles outbreak. So that kind of brings us to, the connection to our communicable disease program and this being a Category 1 illness and kind of are getting questions from different sectors. We wanted to just give you a little update on what we're doing there and a little bit more about measles. So are you ready to jump in? So I'm just sliding so you can, well, maybe there we go.
Thanks, Heather.
Yeah.
I want to preface this with, it's really exciting to get to be with Heather in person. During the COVID pandemic, we were on the phone, it felt like daily when I was supporting one of our nursing homes. And the support that the long-term care facilities receive from the public health nursing staff is phenomenal, and that connection with the state. So really great work that they're doing. But again, really important, this news on the measles outbreak. You know, measles is caused by a virus, so as we deal with viruses, we have fewer treatment options, right? When we think of bacteria, we have antibacterial antibiotics, but viruses don't tend to have great treatment options. It is extremely contagious, so you know, it is going to spread very rapidly. About 1 in 5 people with measles will be hospitalized if they're not immunized and they get, or 1 in 5 people who are not immunized and get measles will be hospitalized. There are complication concerns during pregnancy. It can cause low birth weight and premature birth, and it can lead to some really severe complications. This brain swelling, you may have been reading about if you're reading in the media, and we see this more often in people that don't have good immune systems, so very concerning with that. So how is it spread? Very, very contagious, considered one of our most contagious diseases, spread easily when somebody breathes or coughs. It can live on a surface for up to 2 hours or in the air around. And it is so contagious that if somebody has measles, about 90% of people that are in contact with them that are not immune will become infected. So really concerning. What does it look like? Well, let me tell you, most of us have not seen measles, okay? It has been largely eradicated in this country for a long time. So my generation of physicians have not seen measles live. And that's a really scary thing to me because we don't know what we're looking for. We have the training, we've seen pictures, but having it on the radar is important, and it's really concerning. We continue to spread this to all of our providers to say, be watching for this, but it's, again, not something that most of us have seen. And look at this. It causes a cough, a runny nose, a fever, tiredness, itchy eyes, watery eyes, just like almost every other respiratory infection that we see. At about 3 days, then the rash develops, and the rash is what helps us identify it. But for those first 4 days, people don't show any different signs from other upper respiratory infections, but they're spreading the virus, okay? And the rash will start on the face, spread downward, but rashes often look alike. So it can be very challenging to determine, is this measles or is it Fifth's disease, which is a very common disease in childhood? What are we dealing with? And the only way to diagnose it is through appropriate testing, and that takes some time, okay? Unfortunately, there are no specific treatments for measles. We don't have an antiviral to treat this. The World Health Organization does recommend vitamin A because if people are vitamin A deficient, they have worse outcomes. It's not a treatment, it's something to treat deficiency and help with to improve their outcomes. But we don't have a treatment. We do have very good vaccination, though. The MMR is highly effective, 93% effective with the first dose, and up to 2 doses, we generally get around 97% effectiveness. And because of this, we eliminated measles from the US back in 2000, hence why we haven't seen this, why most of us have not seen this. Another challenge with measles vaccination is that kids or children under the age of 9 to 12 months do not have a mature enough immune system to be able to mount a response to the vaccine. So they remain at risk. Even if we gave them the vaccine, they don't have a mature immune system to protect them. And so part of the concern is not just an individual's risk, but the risk to the community. The fact that this can spread so rapidly, we may not identify it until 4 days in, and by that time, many people are exposed, and many of those people may not have immunity. Okay. Again, with this contagious concern, it's crossing borders easily. A lot of concern around the amount of travel and interaction that we have throughout our world these days. And particularly when we see a vaccination rate below 95%. We've studied this for years and seen that 95% is kind of the threshold that we need to get what we call herd immunity, meaning there's enough people that the virus will stop with them and then it will start to dwindle out, which again, we had achieved that, but we are starting to see a resurgence. So very concerning here is that our childhood immunization rates in St. Croix County are very low, okay? You can see in 2024, less than 80%, down at 70% for 2 doses of MMR in our 5 to 6-year-olds. So We are very concerned about what might happen should that measles virus arrive here. So what can we do? Immunization is our best option. All right, I'm going to give the floor back to Heather. And let her talk a little bit more.
Perfect. So again, one thing our community and all of us can do now before measles continues to spread closer to our community is to check and look at our immunization records if we have them and kind of make sure we're up to date and figure that out and seek more information and learn about the immunization if you have questions and find your records. So this, you see in the slide, the who needs to get a booster. The good news is if you're born before 1957, it's likely you were exposed to measles and you have presumed immunity. So there's that caveat there. If born between 1957 and 1988, you maybe need a booster. You should have received one dose. So it's something to look for and to look to see if there's record of it. But if you fit into now a category of healthcare worker or you're in school, college, you do need, are recommended to have 2 doses. Then in some vaccines, in this little window there, between 1963 and 1967 were this one vaccine was not very good. It didn't really provide the protection needed long term. And so if you got an inactive dose, and that I have to admit is going to be hard probably to determine in any kind of record. I look at Dr. Finley because I know where I can access records, and I don't know that we would see what type of vaccine was given. So that would be another reason if we're unsure that the opportunity there is to get another booster and be up to date. And always check with our healthcare providers. If in doubt, get a booster though, because there's no contraindications to get another dose of MMR vaccine if you've already had 1 or 2. So as long as it's within a good time frame. So, and then born in or after 1989, the recommendation was to give 2 doses. So if you have received 2 doses, you don't need a booster. If you received only 1, and again, are school aged, or if you don't fit into the risk categories, you should get a second dose. And that came just with the recommendations being different for having that booster when there was a resurgence in the early 90s. So there is a little information there. We have a Wisconsin immunization registry. Providers, individuals in the community can look up their immunization records there. If they're having trouble finding them, reaching out to their medical provider. Public health can help look there too, so that we can look for that. We live on the border with Minnesota, and the good thing to know is we do have a lot of people who seek care, and that's where they go for care as well, is Minnesota, but they have an immunization registry, and we do share information. The timing for when those batches come in can vary as well, so if we're in a situation where we have to know right now, and because there's a measles exposure, that's something we can kind of prepare for now by getting the word out in the community. And that's kind of what public health is focusing on, is just what can we do now? We don't, at this point in time, have any measles cases in Wisconsin, so that we know of, so that's good news. But there are things we can do to be prepared. So that's a little bit about this one. And also, I just wanted to mention now that the MMR vaccine is available in all medical facilities providers in the county and most pharmacies. So the public has good access, and public health continues to offer immunization clinics weekly every Tuesday. And we are there to kind of fill that gap, and we can provide vaccines to children who have badger care or medical assistance and who are uninsured. And then we can also provide vaccines to adults who are underinsured or non-insured. So we are there and can help with those situations as well. I wanted to share a little bit about what a measles case investigation would look like. There is an image there of a measles rash on the trunk. It's interesting to see it isolated like that because it can, as we talked about earlier, provider look very similar. So someone might not realize it and they look at that symptom, but that is one that has progressed down the body. But public health, if we get notified of a case, we provide guidance and isolation instructions. We first focus on the person who's ill, and we right away are working with a medical facility, but we need to make sure that person's in isolation, perhaps hopefully well enough to be at home and isolated and stay home away from others. And then we need to work with that, client or family, if it's a child, and really look at potential exposures, where they might have picked it up, so that we can gather that information and give clues to where it might be in the community, and where they were exposed. And then we also then extend out to look at the household and establish close contacts and other exposures that happened in the community. So we need to then contact those facilities, locations, notify of exposure, try to find individuals. Then we contact close contacts to notify them of the exposure, provide guidance, and it could involve quarantine for those folks to have to stay home and hopefully not get sick, but the ones we do and recommend quarantining are at high risk for getting sick. So I'll go into that in just a moment. And with measles investigation, it might require public notices of someone being at a board meeting on April 16th. This is an example that needs to go out there, that if we were in a public space. Here we know who's in the room, so we can contact them directly, but depending on example of timing of public spaces and meetings like waiting rooms at clinics and gyms and different things, we don't know who's all everywhere. In some cases we can figure it out and we can do a direct notification, but other times we have to put out kind of a notice that if you were here during these time frames, you might have been exposed to measles, and we can give guidance to the public. And that's all if there is a case and is an exposure, some of the kind of basic framework. And we're working through those steps with clear direction from Wisconsin DHS. So we're following their guidance and best science they have to help control and keep people healthy. And so we do that in conjunction with their support, guidance, and CDC as well. Well, maybe it will. There we go. Sorry. I just wanted to touch on a couple things when we're doing that investigation. We are talking about, like I said, about isolation. That is for people who have measles or suspect measles. And we start the isolation as soon as we do have suspicion or at the time of diagnosis, and it continues through 4 days after the rash onset. So rash onset 0. That's really key for us because we have to figure out the infectious period that they could potentially have been out in the community and spreading it without even knowing it. So that is 4 days before the rash onset and 4 days after the rash appears. So the infectious period is at least 9 days. Quarantine, we recommend for close contacts, specifically close contacts, the people who are exposed to measles. The quarantine is recommended for those people who are not up to date with MMR immunizations or who do not have evidence of immunity. So we're kind of in a nice situation right now, not knowing or having a case where we can work with our sectors, work with schools, long-term care sectors, the public in general, and just give more information because being quarantined from an exposure impacts a lot of areas and a lot of people. And so we'll kind of give connection to that. But I think that that's where public health is at right now. We want to kind of bring this to the forefront for the community just to be aware, have time to get things in order, get a booster if they need it. Just to give an example, let me just click in here. Just to kind of show how that would work. If you have a child in school or at a daycare and there was a case that was there a couple of days and we get notice, and other people at the child care have workers, so we have other children. So if any of the children there are not up to date with their immunizations, or there's waivers, or there's medical conditions they have where they are not able to receive an immunization, we do need them to quarantine, and that is up to 21 days for the general public. So from the time of exposure. There's a window there where we can work to get people opportunity to get called post-exposure prophylaxis, PEP. But what that means is we can give a booster of MMR vaccine within 72 hours. So if we're in this early window of the first exposure, we can give them some protection. If it's outside of that, again, we have to quarantine. If we're before day 7, people can be out and about, because if they can't get the PEP and we know that the symptoms might start setting in after that. So it's usually between day 7 of exposure to 21 days. It's a little different, you'll see on your slide, with healthcare workers, because we have to be a little more careful there with the timelines. But yeah, back to that child. So your child has to stay home. And again, this is all about their health now. If they don't have evidence of immunity, because we want them, of course, to stay healthy, but because they could spread it without knowing it, we need them to stay away from others. But as parent, now we're home, we're having to find, someone to take care of our child. And then are we, as our household, protected then if they do get sick? And then in a case where our child or it's ourselves, that could impact so many people who if they don't know their immunity status, it delays things, and they may have to quarantine just until they can figure things out and find out if they have, can find their immunization record, or again, it might be past the timeline where they can get a booster, so now they do still have to quarantine, even if they get one for future protection. So I think we want people to understand that there is implications, but hey, if we take some action now, it could really boost our immunization rates in our community, and it could help people that already have some immunity, either by their date of birth, knowing that we have that lifetime if we had measles and are considered, or by having the proper immunizations, or by having a lab draw to test for immunity. So there are cases where we work with our providers to do a blood test to see if we do have some immunity there. If we can't find, and we're like, I know I had that, I know I had them, can we check? That'll give us an indicator. That takes a lot more time than getting a booster of MMR, but again, you might be in a situation where that's what fits best for the health or for the situation. So there's a little bit about the impact it has. I guess in summary, I think this kind of shows that public health is still working hard to serve the community. And when we're watching the news, and we are getting calls from the public, and like I said, mostly our sectors who know that we want to be prepared, schools, daycares, and long-term care, healthcare. We're sharing information, and we're working right now to do some really kind of a blast and increase communication with them and connection to build that system stronger. We are in the process. Adam's been working hard with us in public health to kind of put a little extra information on our website. And you'll see in our public health website, we have some information about our vaccine clinics and communicable disease in general, but we will have a measles page up just to help connect people, because it is so much going on in the nation. We want people to have that information. And again, currently, those numbers are from a week ago, so we still don't have any cases known in Wisconsin, but the immunization rates for children are lower than we'd like to see, and 25 jurisdictions are now reporting cases of measles, 7 outbreaks nationally, and I believe that's up to 5 or 6 of the states with current outbreaks. So now's the time to be protected and be prepared. That's all I have. Is there anything else you want to add at the end? Are there questions?
It's frustrating that we had it eradicated and it's back, so that's super frustrating. I had a question though. So I had the 2 doses because I was one of the 2-dose people. But my doctor said, you could, if you got a test, a titer test, right, to have you look for your immunity, does that wane over time, or is it pretty consistent? So if I was curious or worried, if I got it to like a test and it said, okay, I'm good now, but in 5-10 years, would that be the case?
So we do know you had the 2. We do know that we expect long-term immunity. Doing a titer is a little tricky because it looks for antibodies, and it doesn't look for those long-acting T cells. And you might be able to explain that better than I, Dr. Finley. So sometimes if I have evidence and I know I've had them, but my lab test may not show it, sometimes it's great when it shows it positive. We know that. But when it shows negative, there is some uncertainty there, and it's not as valuable at that point. So if somebody has concerns or isn't really sure about those dates, or maybe just their health status, and want to, again, a booster is an option. So that's, it's an option, but we do expect, though, and we We don't have any recommendations for everybody to go and get another booster of MMR. That's not what we're saying at all. No, this is kind of ensuring that we have, as individuals, oh yeah, I know I had that. But if I came to you or I had to call you tomorrow and say, you know, there's been an exposure and you've been identified, you know, it's going to take maybe a day or two, depending on if you have that baby book, depending on, you know, who you are, if it's in the registry. So that's kind of where we're at. We want people to know that you can be prepared now. Other questions?
I remember my grandparents talking about the measles parties that they would have growing up, where they would get together and nobody died. And honestly, the measles vaccination came about in 1963. The measles rate was 3 and 4 million with 2 deaths that brought this vaccination into play. So when we look at that, is at a 0.013% death rate to a 99.978%. You're going to survive this rate. And I struggle with the amount of aluminum that ends up in these vaccinations that people get, and I worry most about the pediatric population, because as we watch the autism rate, and I know this stuff isn't proven yet, but the autism rate is off the chart, and aluminum is a huge cause of that. Aluminum for us deposits in our brains, it deposits in our livers. I happen to have an up-to-date shot record where I had the 2 MMRs, and then I came back as not having a positive titer because I was a travel nurse. I've been a nurse for 38 years. Because I didn't have a positive, I had to have another MMR when I was, I don't even know, 29, 30. And it still came back negative after having that. So the proof stuff that we have that we're lofting isn't really valid, is all I'm saying. I want to just be clear that there's more to the story. And so with that, I know that Dr. Finley mentioned, you know, the vitamin A. The people that are ill or malnourished are the ones that struggle the most. Are we looking at vitamin A levels in pediatric patients, making sure that they have an up-to-date immune system? The other thing that we know about aluminum is it destroys the immune system. So this is like this catch-22 with all this stuff. And I get frustrated when I hear it, because we're all here to serve people and to do our very best. And I thank you for being out there in the public health and the realm. But when we Google measles or we look at the news, we're going to get a certain amount of information off of that. But if you put it into the Google and you don't start at the top, I don't know, page and a half, because that's going to all be AI, you go below that and you pass through the CDC, the NIH, PubMed, all of the basic ones, and you get further into the weeds where you find the data that's being completely silenced. And we know what we know because that's what we've heard forever. I can't tell you the number of immunizations I gave as a nurse, and I watched babies that were perfectly fine that would be going home the next day, and they would die within 24 hours of getting immunizations, and they were fine. What are we doing?
I have concerns about that. Frankly, because I want Dr. Finley to talk about that study related to autism. It's been debunked, and your point about it being we're going to find the cure. Well, given the current administration, I don't know that I would take that as good science. However, I would like to talk about the link to autism. If you could speak to that, Dr. Finley, and the study that was debunked, please.
Yeah, Thank you. And, I appreciate, Lisa, that we all care about the health of our community, deeply. And there is a lot of information that we have to sift through. I've spent my entire adult life learning and studying this, and my interpretation of the literature is different from yours, is different from somebody else's. But based on my training and knowledge, I fully support this. And, to your point, Kathy, the initial study that was published about autism was a case series, so 12 cases. A case series is lower on the level of evidence, and it cannot demonstrate causation. Okay, it's just a series of, here are 12 cases that I saw in my practice and a connection that I think might be there. And generally it will lead to an additional set of research. That initial case series purported that there was causation from the MMR vaccine for autism. That cannot happen from that kind of research. And it was since stripped out of the literature, and that physician that was responsible actually lost his right to practice and whatnot. We have since, as we should, and we should continue to study this in all ways to understand what happens when we put anything into our bodies, okay? Because the reality is things happen. So we continue to study it. But at this juncture, what we know about MMR vaccination is that it is safe. It is not causing autism. We will continue to study this and every other vaccine, right? We have the most robust vaccine surveillance system in the world here in this nation, and we watch closely to understand what is happening. But again, we at this point do not have any evidence that it is causing autism. Do we need to keep looking for the answer to why we have increasing rates of autism? Absolutely. Absolutely we do. But when we have something that can prevent disease, and at this point, we have a disease that has taken 3 lives, affecting 700 people, we can take some action and help prevent that. So, thank you.
I don't necessarily have any questions. I just kind of like to add to Lisa's statement that, we don't have a proof of what causes autism. But in my lifetime, we've seen it go from 1 in 100 or maybe even 1 to 1,000 down to 1 in 30. And I've got a degree in biology. I'm sure you've got great experience in all of your medical experience. And I look at everything from a standpoint of, okay, it's cause and effect. And is it food? Is it vaccines? Is it the sky? I have no idea. But at some point, we need to get to a true logical conclusion on what causes these things. And I can see, like you're showing, the number of parents are deciding to vaccinate their kids fully at certain ages, school age or high school age or whatever it is, because they see potential cause and effect. And I can see the risks that Lisa's talking about. Like my parents had measles parties and chicken pox parties up and down the block in Milwaukee when they were kids. And the death rate is very minimal. It seems like it's, yes, a pretty tough bug to get over. And with COVID in the back window and people being very leery of latching on to the next scare tactic that we think was coming down the pipe with monkeypox or dog flu, chicken, horse, monkey flu, whatever is coming down the pipe. We are very reluctant to latch on to this idea of, hey, everybody needs to get vaccinated to protect everybody else, when it doesn't look like it's going to affect a massive amount of people in a negative way. Because, the boomer generation's still here. They're more than my generation. They're more than my kids' generation. And they've all had the measles the natural way. And so I don't think that we need to get into, everybody needs to go get a shot, and get your kids shot, and so on. My kids have the ramped up schedule of vaccinations when they were a kid, and nobody else in my family has a peanut allergy except for my first 2 kids. So explain that one to me. So again, I'm sorry I'm rambling, but it is close to my heart because, again, like everybody on this panel, I think we all have the public's interest in mind, and we want to give good advice. So, and again, I think the reputation of the medical industry has been tarnished severely because of what's happened in the last 5 years. So I'll leave it at that.
Well, I think I'll just close with saying we appreciate that people have different understandings and opinions. We will continue to be vigilant and continue to stand to protect the community. So, thank you.
I think that sounds good.
Thank you.
Thank you.
Where are we? Oh, any requests for future agenda items? No. Any announcements? Bob, you always
Yes,
have
sir.
some.
Thank you. I have 2. Well, I'll read them here. Several St. Croix County staff were nominated for the 2025 Putting Families First Award. This award honors those doing exceptional family-centered work and supports families to drive towards positive change. Guardian ad litem Teresa Beyer, Assistant Corporation Counsel Anjali Patel, Children's Services Supervisor Jessica Dodge, and Children's Services Supervisor Matt Zabel were each nominated. Guardian ad litem Teresa Beyer and Assistant Corporation Counsel Anjali Patel were selected for the 2025 Putting Families First Award. A ceremony will be held in Madison on Friday, and congratulations to them. It's quite an honor. And the other announcement I had was the Friend of Public Health Award was provided this morning to Bridging Brighter Smiles. Heather was there for that. And Bridging Brighter Smiles, if you don't know, is a Wisconsin-based nonprofit organization dedicated to providing accessible preventive dental care to children and families with limited access to traditional dental services. And Bridging Brighter Smiles provides on-site services to WIC clients a couple of times a year at the Services Center through coordination with our Public Health Department. Did I get that right? You did. I did. So congratulations to Bridging Brighter Smiles for our 2025 Public Health, Friend of Public Health Award. That was it for me.
Very good, thank you. Any other announcements? Hearing none, our next meeting will be May 21st. And that's, I'll adjourn the meeting. Thank you.